Well, and thank you for joining us today for the Alcohol and Cancer in the United States webinar. My name is Jennifer Leidenberger, and I will be your WebEx host. Before we begin to introducing our speaker for today, I'd like to cover a few housekeeping details. Attendees will be in listen-only mode. Please submit your questions throughout the presentation in the Q&A or chat panel and select all panelists from the drop-down. A moderator will ask the questions on your behalf during the Q&A portion of the webinar. If you need to view live closed captioning, please refer to the media viewer panel. This webinar is being recorded and will be posted online in the near future. I'd like to turn it over to Tanya Agares-Collins, Program Director in the Behavioral Research Program here at the NCI.
Good afternoon. Before introducing our speaker, I want to disclose that the views expressed in this presentation are those of the speaker and not necessarily of NCI. Noelle LoConte is an Associate Professor of Medicine at the University of Wisconsin. She is medical school at the University of Illinois at Chicago, an internship in internal medicine at the University of Wisconsin, and medicine residency at Oregon Health Sciences University in Portland. Completed fellowship trainings in both medical oncology and geriatrics. Dr. is the principal investigator for multiple federal grants and served as the lead author for 2017 Alcohol and Cancer, a statement of the American Society of Clinical Oncology. Dr. LoConte will begin her presentation.
Thank you very much. Thank you to the NCI for inviting me to give this webinar. I also wanted to thank ASCO, or the American Society of Clinical Oncology, for their help with this statement and sharing these slides. And lastly, thank you to my co-authors on this statement. I thought I'd start with some definitions because, as it turns out, how we define alcohol use is variable dependent on the country and who is doing the conversation. I think it's important that we share a common definition of what a drink means. In the United States, the NIAAA defines binge drinking as a pattern of drinking that brings the blood alcohol concentration to 0.08 grams per deciliter. In women, that translates to 4 or more drinks in one sitting, and in men, that is generally 5 or more drinks in one sitting. Drinking is defined as 8 or more drinks per week in women and 15 or more drinks per week in men. For purposes, we define high-risk drinking situations to include drinking any amount while pregnant or youth drinking as well. You may also hear agencies define that as excessive drinking. A drink is a beverage that contains approximately 14 grams of pure alcohol. Thus, percent of alcohol defines the volume. One standard drink is 12 ounces of a regular beer, 5 ounces of wine, or 1.5 ounces of spirits. Be careful of microbrew and malted beers, which can have a lot more alcohol by volume. This can make the public understanding of alcohol use confusing, but it can also make studying alcohol use very difficult. Making it confusing, not all beverages are required to list their alcohol content on the container. This is a screenshot of our statement on the right, and on the left are some figures to show you that alcohol use is on the rise. 35% of all United States cancers are alcohol-associated cancers, and this is 5% globally. In addition, the rates of total and high-risk drinking are also increasing rapidly, both in the United States and globally, which means we will see alcohol-related cancers increasing in numbers in the future. In 2018, the American Society of Clinical Oncology released a statement, Alcohol and Cancer, a statement of the American Society of Clinical Oncology, which has reviewed the data associated with alcohol and cancer and supported various public health strategies to reduce the burden of alcohol-related cancers, called out various areas of needed further research, and delineated the role for the oncologist in addressing alcohol. I mentioned that the American Society of Clinical Oncology is the largest professional organization for cancer care providers and is both a United States organization but also has global representation. This is here from a study by Dr. Tapper and colleagues from the University of Michigan, published this year in the British Medical Journal, and it shows that from 1999 to 2016, United States annual deaths from both cirrhosis and hepatocellular carcinoma have doubled. Notably, this is driven in part by increased rates of death due to cirrhosis in patients aged 25 to 34 years old, which for clinicians on the call is extremely young. The bulk of the increase in deaths from cirrhosis is to alcohol-related disease versus being related to something like hepatitis or obesity. Note that liver cancer or hepatocellular carcinoma is also one of the alcohol-associated cancers. You may be wondering, why did we choose to put this statement now? On a personal level, I wanted to put this statement out because I realized my peers, even in oncology, were not aware of the true impact of alcohol on cancer. For example, many did not know when to check the yes box on the death certificates that we find that asks the question, was this death related to alcohol? The reason I put this statement out now is to begin to address the general lack of awareness of alcohol as a carcinogen. For example, in 2017, ASCO commissioned a survey of United States adults, a lay population, and in this there was a fair representation of people that had been either personally or in their family affected by cancer. But despite this, only 30% were aware of alcohol as a cancer risk factor. As a contrast, this number is even lower in England, estimated to be 13%. However, if you look at the numbers for tobacco, which is high at 78%, and UV or sun exposure at 66%, there's clearly a long way to go for us to raise awareness about alcohol and cancer. Many people are aware of all the other risk factors of alcohol, including motor vehicle accidents, physical sexual assaults, for example. Thus, we felt the real opportunity here to raise awareness of related risks of alcohol. This thing was further reinforced with similar NCI publications of global understanding awareness of the link between alcohol consumption and cancer across the world by Drs. Schiller and Klein, with the major finding quoted here. It says, a review of 32 studies and surveys conducted across 16 countries, we have a great deal of variability and awareness about the link between alcohol consumption and cancer risk. Appeared to be highest in the United Kingdom, Morocco, and Australia, although awareness in these countries is still modest. Here's another piece of data reinforcing that the public is unaware of alcohol as a carcinogen. This is from the NCI HINTS, or Health Information National Trends Survey. In this question, 3,281 people responded about risks of heavy alcohol use. For example, only 34% were aware of the risk of cancer from, quote, drinking too much alcohol. What's more concerning is that 20% thought there was no association at all. Contrast with the risk of liver disease at a very high 87.5%. The study further estimated that this would translate into about 67 million U.S. adults who are unaware of the risk. So in other words, we have our work cut out for us. So why do we think this is important, this awareness? We know that when people are aware of alcohol as a risk for cancer, they're likely to support various policy strategies aimed at reducing rates of high-risk drinking, which we believe is the most effective strategy to reduce alcohol-related cancers. The data presented here is from an English study of 2,100 adult residents. As I told you, 13% were aware of the alcohol and cancer link. Increased awareness of alcohol as a carcinogen was associated with increased support for 4 underlying policy concepts: availability, market information, harm reduction, and driving reduction. Moving on to the epidemiology of alcohol-related cancers. First of all, as I told you, alcohol use is increasing, and not surprisingly, alcohol-related cancer numbers are also increasing, both in the United States as well as globally. Alcohol-related cancers account for about 3.5% of cancer deaths in the United States, which amounts to about 21,000 potentially avoidable cancer deaths per year. Alcohol-related cancers have an even higher burden globally, with 5.8% of all cancer deaths being attributed to alcohol and 5.5% of new cancer diagnoses. Both numbers are increasing over time. By absolute numbers, you can see that the numbers of affected patients are highest among breast cancer patients and neck cancer patients. Said another way, although the relative risk for breast cancer from alcohol is not as high as some cancers, breast cancer is very common, making this total number high relative to other cancers. We do have some ideas about the predictors for heavy alcohol use. First of all, underage drinking is a clear risk factor for heavy drinking later in life. This was notably highlighted in the Surgeon General's Call to Action to Prevent and Reduce Underage Drinking, published in 2007. Currently, recent surveys show that many young people are drinking. 13% of youth aged 12 to 20 years old currently meet the criteria for heavy or binge drinking, and 6% already meet the Diagnostic and Statistical Manual of Mental Health Disorders, number 4, criteria for alcohol use disorder. Youth that drink are much more likely to be adults that drink. Other factors are being younger, being male, have a family history of alcohol use disorder or heavy drinking, race or ethnicity, which I will get into with a later slide, gay, lesbian, bisexual, or being a current smoker. We'll discuss socioeconomic status on a later slide, though that is also somewhat of a predictor. Major organizations that have made recommendations about how much adults should be drinking alcohol, including the American Cancer Society, the American Heart Association, the National Institutes of Health, and Department of Health and Human Services, have all been very consistent. The recommendation is to drink up to 1 drink per day for women and 2 drinks per day for men, drinking underage, and if you don't drink, don't start. Men also recommend no drinking while pregnant. See a figure here from the NIAAA explaining the guidelines and also stating that you should stay within both the daily and the weekly limits to be considered low risk. I think it is interesting to read the American Heart Association's take on this, and I've taken this quote directly from their website. AHA does recommend that to reduce your cardiovascular risk, you should talk to your doctor about lowering your cholesterol and lowering your blood pressure, controlling your weight, getting enough physical activity, and a healthy diet. There is no scientific proof that drinking wine or any other alcoholic beverage can replace these conventional measures. So what cancers are we talking about? One important point is that we are not speaking about all cancers. When discussing alcohol-related cancers, currently we are speaking of 7 cancers: mouth, throat, larynx, squamous cell of the esophagus, female breast, liver, and colorectal cancers. The International Agency for Research on Cancer, or IARC, is an intergovernmental agency that specifically investigates carcinogens and rates and trends in cancer. It's part of the World Health Organization. Alcohol has been a carcinogen on the IARC monograph since 1988. This is revised on a regular basis. And we expect that with ongoing revisions to the IARC report that more cancers will be added to the list, including pancreatic adenocarcinoma, gastric cancer, and possibly lung cancer. The ASCO statement specifically states that lung cancer is often confounded by tobacco use and alcohol use frequently coexisting. There is also a suggestion that alcohol and smoking may be synergistic for oral cavity, pharynx, larynx, and esophageal squamous cell cancers. Here at the University of Wisconsin have developed this take-home point that the more a person drinks and the longer the period of time, the greater risk of development of cancer, especially head and neck cancers. We believe it's important to keep some of the focus on these heavy drinkers throughout our conversations about this statement. That is to say, the focus on is 1 drink a day healthy or harmful is not really where the data should lead us to concentrate. So what is the magnitude of the association? This table was taken directly from our paper, and it is a composite of a meta-analysis for alcohol effect sizes. We chose not to break out gender to make the table as simple as possible. You will notice that there is a dose-response relationship. Also, please note that risk does increase with light use for some cancers, notably for breast cancer. Unsurprisingly, the strongest association is with those tissues that directly contact the alcohol. And please note the very important dose-response relationship with oral cavity and pharynx, esophageal squamous cell carcinoma, and breast cancer. So one question is, okay, if I cut down or I stop drinking now, does my cancer risk decrease? And the answer appears to be yes, but not for a long time. The best data is seen with head and neck cancers and esophageal squamous cell carcinoma, where the models all suggest that it takes about 20 years to realize a risk back down to that of a non-drinker. See on this slide are three figures across many studies for esophageal risk in the top figure by Jarl and colleagues, and neck cancer risks in the bottom two figures by Chiadaruri and colleagues. It is really unclear for all the other alcohol-associated cancers, however. For example, in breast cancer, alcohol does not appear to affect risk in people who are carriers of a BRCA gene mutation. This is from a case control study published in 2010 by Dennis and colleagues, as well as a prospective cohort study by Subolski and colleagues published in 2015, among other studies. There are many methodologic issues to account for. For example, the onset of cancer-related symptoms may lead a person to stop drinking, and forward drinkers may be overrepresented by alcoholics and heavy drinkers. This concept is broadly termed an abstainer bias. We question of risk of cancer after alcohol use is decreased or stopped is a critical area of needed further research. The mechanisms by which alcohol causes cancer. To begin with, alcohol is converted via alcohol dehydrogenase to acetaldehyde, which is a known carcinogen. This acetaldehyde then touches the tissues of the head and neck as well as the esophagus. So direct contact is how these cancers develop from alcohol. We know this is true because of some important work in East Asian populations who have a higher prevalence of the enzyme ALDH2, which is acetaldehyde dehydrogenase, with a variant called RS671-2, with a less active enzyme to break down the acetaldehyde. This results in longer exposure time to the carcinogen. Indeed, we see higher rates of head and neck cancers in this population that is homozygous for this enzyme. For the other cancers, there are different mechanisms. In colorectal cancer, alcohol appears to affect folate absorption, with low dietary and serum folate levels being a known part of the pathway in colorectal cancer carcinogenesis. For cancer, alcohol intake increases blood levels of estrogen, which is known to increase the risk of hormone receptor-positive breast cancer. There has also been hypothesized that given that alcohol dehydrogenase is present in breast tissue, that may be part of the causal pathway as well. Both of these are intriguing when taken with other studies that show there may be a window of vulnerability for breast cancer, such that a woman is at higher risk for alcohol-associated breast cancer when she drinks before first full-term pregnancy or lactation. There's particular relevance to college-age women who are much more likely to engage in binge drinking and also more likely to not have had their first pregnancy. For liver cancer or hepatocellular carcinoma, which is the same thing, alcohol causes cirrhosis, which is a cycle of injury and repair, which is the precursor to the development of liver cancer. There are known disparities in alcohol use and alcohol-related cancers. Binge drinking rates in young Native Americans is higher than in other populations. You can see the binge rate among Native American youth, again defined as ages 12 to 20, is 28%, while binge use rate in other populations is lower, with whites at 23%, black 22%, and Asians at 14%. Alcohol is associated with 11% of Native American deaths, which is over double the rates for other subgroups. Here on this slide is from the LIC article looking at substance abuse rates among various racial and ethnic subgroups of adolescents. Black and Hispanic populations have higher rates of abstinence from alcohol, but when either population does drink, there is more alcohol consumed and the binge drinking rates are higher. In addition, both populations appear to be more sensitive to developing alcohol-related liver disease. This is another area that we believe needs further research. Socioeconomic status is inversely related to alcohol use. From Lynn's article, and this is a direct quote, "The literature has supported a positive relationship between socioeconomic status and alcohol use, such that individuals with higher SES or living in areas with higher SES engage in more frequent and heavier drinking. However, this relationship may be moderated by other individual-level variables such as drinking status, gender, race, and ethnicity. Notably, when lower socioeconomic status patients drink, they do tend to suffer more negative consequences, effects of their drinking, such as accidents or death. Established that the LGBTQI populations use alcohol and tobacco and other illicit drugs at higher rates than heterosexual cisgendered populations. I am not aware of any studies specifically looking at alcohol-related cancer and the LGBTQI population. However, I would like to bring your attention to another recent ASCO publication about the care of LGBTQI patients with cancer by Dr. Jennifer Griggs and Glaze, that specifically reinforced the importance of addressing substance use with these patients because of their higher rates of alcohol use. Women actually are less likely to drink, but they are also less likely to use alcohol-related treatment services. This presents a unique opportunity for improved outreach and intervention. Sorry about that. Forward. I'm going to get us back on track here. You get a peek of all my slides. So about the effects of drinking after you've been diagnosed with cancer. Immediate concern to cancer patients and their providers is what do we tell this patient when they are currently drinking? There is data to support providing counseling patients with head and neck cancers to reduce or stop their alcohol use. Among patients with head and neck cancer, there is good data to show that continuing to drink increases the rates of recurrence, increases the rates of cure, and increases the rates of second primary cancers. How much counseling is being done in practice is not known. Optimal ways of counseling patients is also not known and is another area for future research. We also know that among all cancer patients, those who are higher drinkers have higher overall total mortality at 8% and recurrence risk at 17% relative to the lowest rate drinkers, and this is from the Schwedhelm paper. In that, we really don't have good data. In fact, breast cancer studies are particularly difficult, and some of the larger studies are summarized in the table on this slide. You can see there are 4 large studies which all have conflicting findings. For example, in the collaborative breast cancer study, there was no effect on recurrence with continuing to drink. The study did not look at any special populations. In the breast cancer pooling project, a whole cohort analysis did not show any association with alcohol use and recurrence. But a subsequent study looking just at postmenopausal estrogen receptor positive patients did show increased risk with continuing to drink alcohol. This is the type of cancer that would be most predicted to be affected by alcohol use. This is breast cancer, I should say, that would be most predicted to be affected. Across all of these studies, there are methodologic concerns, however, including relatively few cancer-specific mortality events, relatively low rates of alcohol use across the studies, and most of these studies focusing on pretreatment but not post-treatment alcohol use. Thus, this is another area of needed additional research. What do we know about how alcohol use affects cancer treatment? We do have a better handle on this with the literature currently published. Here is a summary of many studies with similar findings. Drinking alcohol makes cancer treatment harder, and it makes it higher risk. For example, in head and neck cancers, those who continue to drink have higher rates of a serious radiation-related complication called osteonecrosis of the jaw. Those who drink alcohol also have longer hospitalizations, increased number of surgical procedures, prolonged recovery periods, high costs, higher mortality, and higher number of surgical complications. People that drink a lot of alcohol also have an increased number of comorbidities going into their cancer treatments, which can affect their risk of surgery. There are also barriers to getting this word out about alcohol and cancer. First, there is the low provider knowledge that I discussed earlier in the presentation, but also low lay population knowledge that we've also reviewed. Like with counseling for obesity, with obese providers being less likely to do that, we know that providers who use alcohol are less likely to counsel their patients or inquire about their patients' alcohol use. Furthermore, oncology is a field where burnout is common and substance use is more common amongst burned out healthcare professionals. the most pervasive barrier by far is the belief that maybe that a little bit of drinking might be healthy for your heart. The jury is still out on this, and there are data and studies to support both sides of the argument. But I think we can all agree that a lot of drinking is never healthy, and that if you don't drink, you shouldn't start. Or more succinctly by this cat meme, alcohol is not health food. Well, and it's no wonder that people are confused about what to do. I pulled these two figures from two articles published in the exact same month in the exact same journal, which was The Lancet. Both of the manuscripts got, I think, an equal amount of lay press coverage. And on the left shows that maybe a small amount of alcohol per week is helpful, particularly in reducing cardiovascular events. Then a couple of weeks later, the figure right was published, a study that was a model using the global burden of disease study, showing that for a composite endpoint of disability, all-cause mortality, and cancer, there is no safe amount of drinking. But then I think we can all agree, even across both of these figures, heavy drinking is always bad. The state also took the opportunity to specifically support various public health strategies to decrease high-risk alcohol consumption. I'd like to list these for you here because I think it's important that ASCO specifically supported these. One, clinical strategies of alcohol screening and brief intervention, bringing alcohol outlet density, increasing alcohol taxes and prices, enhancing enforcement of laws prohibiting the sale of alcohol to minors, reducing youth exposure to alcohol advertising, resist privatization of alcohol retail sales in communities where there is current governmental control, ending alcohol control strategies and comprehensive cancer control plans. And that brings me to a logical partner in this work, the Centers for Disease Control State Comprehensive Cancer Control Programs. As many of you likely know, every state and many territories and tribal organizations have a state comprehensive cancer control program. Please note that this is different than the National Cancer Institute's Comprehensive Cancer Center designation. These groups are based at your state Department of Public Health, for example. CDC defines comprehensive cancer control as a collaborative and strategic approach that brings partners together to combine, share, and coordinate resources to reduce the burden of cancer across the whole cancer continuum. Each of these state cancer programs are asked to develop a plan every few years as to how they are going to address cancer control in their state. There's an opportunity to work with these coalitions to continue to educate about alcohol and cancer. However, based on a paper by Henley and colleagues, only half of comprehensive cancer control plans included any objective or strategies related to alcohol use, although most of them did acknowledge it in the text as a risk factor. Another opportunity exists for the NIH-designated cancer centers. Most have some information on their website as I peruse them, alcohol and cancer, and many have at least one faculty who is interested in the issue. But few have organized programs around alcohol and cancer, unlike what is seen with tobacco, for example. To give an example of how we've operationalized this work in our state, here is some of the work that we have done around alcohol and cancer. If you know anything at all about Wisconsin, you know we have a very significant problem with alcohol. So this issue that the state's coalition felt was important to work on. Start top right, we create a frequently asked questions document for us to use and distribute. Below that, we have an infographic about alcohol and cancer. We have mapped out our policy committee agenda to support environmental approaches to reduce high-risk drinking, which were spelled out in the ASCO statement. We have formalized our plans for work around alcohol and cancer for the near future in what we are calling an action plan, which was developed with statewide input. I want to make sure you were aware that the ASCO statement also called out pinkwashing, which we have found not everyone is aware of as a concept. Pinkwashing is a marketing approach for alcohol that uses pink ribbons and pink coloring to show a commitment to finding a cure for breast cancer. We think that this does not make sense because alcohol causes some breast cancers. It would sort of be similar to selling cigarettes as a way to raise awareness for lung cancer. So our statement specifically said that we would like to see pinkwashing stopped. The future directions for ASCO after this statement, we did have our annual meeting education session at this last annual meeting in 2018. I'm going to say that session was very well attended, and because of that session, we also were able to produce an educational book manuscript. These are relevant because they are freely available on PubMed and generally have a very far global reach because they are free. We've produced podcasts, both patient provider facing as well as a video chat for patients, and been participating in alcohol control symposiums with interested partners across the U.S. ASCO isn't actively monitoring for related legislation, but we stand poised to support legislation that may reduce high-risk alcohol consumption in line with the policies supported in this statement. What came much surprise to me was the media attention that this statement generated. I have a few slides on this, but suffice it to say that none of us were expecting this level of attention. The major outlets that picked up the alcohol statement included CBS News, CNN, Fortune, Fox News, Good Morning America, Healthy, Mother Jones, NBC Nightly News, New York Times with multiple stories, NPR, Time, and 2 articles in Vogue. Also got a companion editorial published in The Lancet, which was not where our statement was published. Our statement was published in the Journal of Clinical Oncology. But shortly after our statement was published, The Lancet put out this editorial in support of our statement, saying that we need to stop arguing about whether alcohol causes cancer. The evidence is clear, and it's time to move on action. So we were very happy to see this editorial. This is from the statement itself. You can click through and see exactly where we've been cited. I told this via score or tension score of over 1,700 is high. Our article was the #1 most downloaded article from the Journal of Clinical Oncology last year. And here you can get a global sense of where we got some attention, with Spain, interestingly, being the highest area outside of the United States. So I wanted to boil this all down to some basic take-home points. I think one thing that's very clear is that it can be very easy to get bogged down in the details with the statement, and we should all have clear, concise talking points because this is as much a public-facing issue as it is a provider-facing issue. These are the talking points that we have developed. That alcohol use increases the risk of 7 different cancers. And low levels of drinking can increase cancer risk, but the greatest risk is with heavy long-term use. Strategies that are shown to reduce excessive drinking, define heavy underage or binge drinking, have the potential to decrease the burden of cancer in Wisconsin and certainly across the United States. As I said, these talking points were developed by our group here in Wisconsin. And to reduce your cancer risk, drink less. If you do not drink, do not start. Clear media attention. There is a hunger out there to discuss this issue, so I think we should capitalize on that, but we also need to be really consistent in messaging. And lastly, before we roll into the FAQs, I wanted to highlight the areas of suggested future research. This is how decreasing alcohol use affect future cancer risk, how do you understand and evaluate the increased sensitivity to alcohol-related liver disease in non-white populations, what does continuing to drink have on cancer and cancer recurrence, especially for non-head and neck cancers, and what effect does drinking have on cancer care delivery? For example, there's very little work that's been done on chemotherapy, dose intensity, side effects, etc. Final slide is some resources that would be of use, like the patient-facing podcast, the educational book manuscript, which I said is free, the FAQ sample, which you're welcome to use, and then an excellent Science Friday podcast about alcohol and cancer and the complexities of doing clinical trials and clinical research in this space. With that, I'll turn it over for questions.
Thank you, Dr. LoConte. I'd like to jump into questions from our audience. As you can ask a question by typing it into the question and answer or chat box, and all panelists. Let's with the first question. Is there evidence that drinking after diagnosis is associated with greater metastatic progression or worse 5-year survival for hepatic carcinoma or breast cancer?
So the answer to that question, so for hepatocellular carcinoma, starting there, I'm not aware of any definite data, but it would stand to reason that the cirrhosis, the reason why that cancer developed, that's not going to be reversed necessarily by stopping drinking, so that the risk would continue. Many patients with that type of cancer go on to have second primary liver cancers as well, not just recurrences of their original one. As far as breast cancer, I walked through a little bit of that data, but I think it's all over the map. There's some data to support that it might affect particular hormone receptor positive breast recurrence, and then there's some that don't support that.
The nation, how do you define heavy alcohol use and long-term use?
Long-term is not well defined. I will agree that could be clarified. Heavy drinking is defined as 8 or more drinks per week in females and 15 or more drinks per week in males. Drinking is defined as 4 or more at one sitting in females, 5 or more in males.
Work in lung cancer on pictures for cigarette smoking seen on analysis of tumors. Do you know of anything similar that has been shown in cancers such as hepatocellular carcinoma and breast cancer?
I think the question is driving at genomic sequencing in those cancers, and I'm not aware of any that are particularly linked to alcohol, which I'm not aware that the research has been done, not that it was done and it was negative. So another area where we need more studies.
The question, had alcohol use interventions been tested in the treatment setting?
Not much. I think this question is driving at, do we know the right way to counsel patients with cancer who are currently using alcohol? And there is not a lot of data out there to support how providers should do it. There is a moderate amount of data, I would say, in primary care settings, particularly around alcohol and also tobacco. There's some really good data around counseling for reducing tobacco use in cancer patients. That would be a logical place to start. But I think right now, I couldn't tell you the right way to tell oncologists to talk to their patients, other than we know that members are not even asking at all about alcohol use, and that would be a reasonable place to start, to have a conversation about how much are you drinking.
Can you explain more about the relationship between risk of colorectal cancer, alcohol, and how folate is related to that?
So patients that drink alcohol have lower folate levels in their blood, and they also are not as able to absorb folate, and likely their diet is not as balanced, meaning they eat less folate if they drink a lot of alcohol. Folate is a part of the development of colon polyps and colon cancer. So we've known for a long time that diets low in folate or patients with low blood folate levels are at risk for colon cancer. It's just that we also know that alcohol is a contributor to those low folate levels. But presumably, if some way to address the low folate levels, then the colorectal cancer risk would be reduced.
Follow-up to that particular question, what can people do if they want to drink? What can they do to metabolize the alcohol to get it out of their body so that it's less toxic?
Less? I don't know that there's any great I think under those guidelines of 1 a day for women, 2 a day for men. I'm aware of any data that would support, drinking over a longer period of time or a different type of alcohol would necessarily counteract the effects.
Okay. Are there any studies that have relied on measures of alcohol consumption that do not rely on retrospective self-reports?
Mm. I'm aware of some prospective data out of Europe where patients did like a food diary web in real time, but this question is exactly in that we often rely on retrospective, you know, how did you drink last month kind of questions. And further back ask, the less reliable the answers, meaning if you ask somebody, what did you drink last year, that's not particularly robust way of measuring alcohol use.
I have two questions that are similar. For example, where and how does education begin in order to bring more attention to this information? And what strategy, for example, would be used to reduce drinking among college-age drinkers?
Yeah. That's an excellent question. Well, as I said, I think there's a hunger out there to discuss this issue, so getting an expert who's willing to talk to the media, talk to patients is a reasonable place to start. Educating those of us in cancer about the carcinogenic effect of alcohol would be a good place to start. I think touching on that pinkwashing issue, we would all be wise to recommend within our organizations and institutions that incentivizing alcohol use as a way to raise money for the research is probably not a great strategy. I think, you know, just continuing to have this conversation, I think the question about the college-age drinkers is really an excellent one and probably best poised to somebody who's a policy expert, which I am not. As I've been talking to college-age people in my institution and across the U.S., I don't think many people are even aware at all of this concept of a window of vulnerability. So there are a number of college organizations that could be logical partners in doing this work. And I think we need to further study it to really know for sure if that's, now I would say it's a hypothesis. I wouldn't settled science, so that would be an important next step for where we go with the research.
We know about alcohol use and misuse among cancer survivors.
Yeah, too much. We know that head and neck cancer patients are commonly continue to drink. We know that many head and neck cancer patients are not told about the risk of cancer recurrence. If you're in a single person study, the two articles in Mother Jones were about a journalist, Stephanie Mensimer, who was diagnosed with breast cancer and had no risk factors that she was aware of for cancer. She went through lots of treatments and counseling. She saw a dietitian, multiple providers. Nobody ever told her about alcohol and breast cancer, and as it turns out, she was drinking alcohol fairly regularly and certainly more than recommended. And so these articles are really about how to get that message out to cancer patients who might be interested in knowing all of the possible risk factors, and why are we not talking about it?
Can you speak to the confounding of smoking and alcohol consumption, particularly in older research?
Yeah, it's an excellent point. I think that the two definitely do go hand in hand. It's a little bit like the coffee and smoking story. I think there are careful methodologic ways that we can separate them, and I think that many of the cancers that we're talking about are not necessarily smoking-associated cancers. But yes, that would be something to watch for when you're evaluating this research. Thankfully, people are smoking as much anymore, so hopefully this will become clear as we continue to do further research. Alcohol use, though, is increasing, so become clearer.
About the role of alcohol use versus other social factors that typically accompany alcohol use disorders and treatment effectiveness and quality of life among patients with cancer.
Repeat the question. I just want to make sure I...
Yes. What do we know about the role of alcohol use versus other social factors that accompany alcohol use disorders and with treatment effectiveness and quality of life?
Yeah. So we know that patients that drink alcohol are more likely to be male. They're more likely to be unpartnered. They are less likely to get routine preventive health care. Not aware of data that would suggest that they necessarily access, once diagnosed with cancer, that they access cancer care treatments less frequently, but that could be possible. I don't think the work's ever been done. Also, one of this question is driving at nutrition. We know that patients that drink alcohol generally have poorer quality diets, which may be a risk factor for cancer and cancer treatment complications. This, again, is for these heavy drinkers, which I think is where the focus should start with this work.
Do you have any data on concurrent marijuana use? A lot of the cancer patients smoke weed as well as drink alcohol.
Yeah, correct. No, I'm aware of no data.
Culture needs to change at events like conferences, not happy hour where there's alcohol. Yes. Speaking only myself here, I think that we need to get away from things like bar crawls for cancer research or events where the more you drink, the more is raised for research. I can't think of another example where we directly promote a carcinogen as a way to promote cancer research. I think it is a different story when we're talking about having an event for adults where there happens to be, for example, a cash bar, but there are other non-alcoholic options available. I think for me that's less egregious. But a reasonable place to start would be to ask professionals that do cancer events not to be using alcohol as a fundraising event. Do animal models of excessive alcohol consumption recapitulate cancers observed in humans? So, yes, the answer to that is yes. It's largely mouse data. Data is not perfect for some of the cancers that we're discussing, in particular pancreas cancer. So not all of these cancers necessarily have great models, but in general, yes, the animal data is supportive of the human findings as well. Have you considered approaching large groups such as Susan G. Komen to pursue an effect to educate the public on the risk of breast cancer and alcohol given their large population? It might be a very good way to reclaim the pink washing to our advantage. Yep, and pink washing as a concept was defined by breast cancer survivors. It was not claimed by academics or professors, so for credit where credit is due, that came from the patients. This thing about reaching out to larger organizations is a good one. I personally am not a breast cancer doctor. I'm a GI cancer doctor, so I don't think it would make sense for me to be the one to do it. And I know that, for example, the American Cancer Society is aware of this issue and is having discussions about it. But the point is taken that we have bigger reach if we reached out to other organizations. Has any work been done looking into the role of addiction treatment in the course of cancer patients? There's been quite a bit of work in tobacco and really, really excellent superlative work. I would say that the way we address tobacco use is different than the way we likely will need to address alcohol use, and so you can't make a one-to-one connection necessarily with what learned in tobacco, but it would be a place to start. The reason is that the message for alcohol is likely a little bit more nuanced, meaning we can clearly say to a patient, you should never, ever smoke again, and be completely correct, whereas not all cancers that are alcohol-related, it's not all amounts of drinking that necessarily increase your risk. We don't even know the right answer, for example, in women who are BRCA carriers. So it's a messier message, which can be difficult to translate accurately to patients. And you lay on top of that many physicians also enjoy alcohol, which makes that counseling all the more difficult. It's like a lot of research that needs to be done will be large-scale population-level studies over many years. Are there research areas that can be achieved in a shorter amount of time? A shorter study would be, for example,
example, look at the right ways to counsel these patients. They ask about alcohol use. We could pilot various tools, for example, about how to counsel patients and families about alcohol. Are they even aware of the association? I think work with younger women could be done in a relatively short amount of time, looking at breast cancer risk and how that would modify their choice to drink, which would have some side effects because, as I said, other risks of alcohol, not just cancer. So I do think there are a few kind of low-hanging fruit ones that we could do, or we could also do with currently in existence data sets. But I agree with the person who's asking the question. A lot of this work is going to be large prospective studies.
And comparable studies in other countries where they cut a number of risk factors, including diet?
There's been quite a bit of data that came out of Europe and showing similar findings in the United States. I think that's probably why Lancet, which is a European cancer journal or medical journal, mentioned statement in their editorial. All of them are fairly consistent in terms of what cancers are affected, what amount of drinking, the relative risk of whether you're a light drinker, moderate drinker, or heavy drinker.
Are other organizations or institutions that you are working with or that you're aware of that broad media exposure aimed at the public, or aimed at decreasing alcohol consumption among high school students?
Sure there are. I'm speaking only on behalf of the American Society of Clinical Oncologists and the specifically Prevention Committee. But I know alcohol in general is of concern to, as I said, primary care providers, pediatricians, internal medicine doctors, family medicine, not just because of cancer, but because of the risk of motor vehicle accidents and sexual assault and those kind of things as well. We're adding a little element to the whole conversation about the risk of cancer. We felt like got lost in the conversations about alcohol.
You mentioned your research and areas where additional research needs to be conducted. That Hispanics are more sensitive to developing alcohol-related liver disease. Do you think this is more related to genetics than alcohol consumption, or both?
I think it's really unclear. I think genetic reason off the top of my head, but I'm not a hepatologist. I think it probably has more to do with other things like access to quality food, education, housing stability, et cetera, that likely are contributing factors. I'm not aware of any particular gene that would necessarily drive that finding.
Question. So low dietary folate intake is a risk factor if you're drinking alcohol. Can you increase folate intake to decrease your risk for cancer?
We don't know yet. So it looks like increasing folate decreases risk of spina bifida. That's why, cereals, for example, are supplemented with folate to reduce pregnancy complications. I don't know that we've ever been able to show that folate supplementation reduces risk of colon cancer, but partially that's because it's a really long outcome, right? You'd have to start using folate and then look at outcomes 10 years or more down the road, which would be a really long study to do.
Perfect. Thank you so much, Dr. LoConte and Tanya, for your kind of the moderating and the questions. I do want to be respectful of everyone's time since we are coming up upon 3 o'clock shortly. As I mentioned earlier, this presentation will be posted online in the near future, and it'll be at cancercontrol.cancer.gov/BRP webinars. It'll be posted within the next 2 weeks or so. Please feel free to continue the conversation. We'll keep the chat box open for a little bit for any additional questions that we can pass on that were not answered today. And again, I want to thank everyone for your participation and the great questions that came in that made this a very interactive webinar. Thank you and have a great rest of the afternoon.